Thank you, Talal. Do we have few questions?
Can we invite the speaker to the stage, please? Prof. John Marshall, Sebastian, Talal, and Hiba. For sake of time, only 2 to 3 questions. We'll start with Dr. Hamad.
Okay. Dr. Marshall, Dr. Christian, the question is for you. If we have penetrating fistulizing disease or structuring disease, how do you go with infliximab maximum dose and shortening the period? And if there is any point to change from infliximab to adalimumab? And what will be the second option in fistulizing disease? This is for you.
Okay. Always good questions. No, I don't think out of the gates I would be using, I would use standard dose infliximab to start in a patient who had penetrating disease, but I would be very thoughtful to dose escalation, and those sick patients with high inflammatory disease burdens are the ones where I'm more aggressive with dose escalation. I have this concept in my mind, unproven, that what I'm really trying to achieve is adequate local tissue concentrations. I think in patients with particularly penetrating disease, that is difficult unless you have higher serum levels. So I do push the serum levels between 10 and 20 at minimum, and I think there's some evidence to support that. So I wouldn't start at a higher dose, but I'd be more aggressive with dose escalation. If anti-TNF fails, I'll stay here. I probably wouldn't, go to a second anti-TNF because in that scenario, I'm actually doing proactive TDM, so I know I've actually got an adequate trough level and it's failing. I think all classes are probably potentially effective in that second line setting. I think we do have some data UPA with the subgroup analysis. I think we've got some data historically with vedolizumab and subgroup analysis from the clinical trials. But generally, those sick patients, I think the second line after anti-TNF failure might be a JAK inhibitor. Yeah.
Okay, Sebastian, the question is always whenever we have, this is here. Dr. Sebastian? Hello? Dr. Hamad, gastroenterologist from Jeddah, Saudi Arabia. The question always, we have shortening of astakinumab, shortening of INT'L, shortening. If there is any point of doing this, or nowadays, let's say if astakinumab 8 weeks, 4 weeks, there is no, you just shift. What do you think in the era now? And the same for INT'L.
I think the dose escalation probably other than outside of TNFs is perhaps not based on solid evidence. There are observational data which suggested Q4 ustekinumab may be useful. In our practice, we did do that initially, but now if somebody is not responding, we don't escalate. And the CView and other trials have shown that dose escalation, particularly with ustekinumab, does not make any difference. Vedolizumab again does not make any difference. So probably the only one where dose escalation I would try is anti-TNF.
Hiba, actually, Dr. John Marshall showed us very important slide, and I love it, that 1 millimeter reducing the thickness, it will widen your tube. And this is really the intestinal ultrasound. So if 1 millimeter is reduced, I think it's an amazing. How we are good in putting the cursor. I'm very meticulous. 1 millimeter is very tiny. How you are sure to do that, Hiba?
So thank you, Dr. Hamad, for these questions. And
you have to do it the same place and the same person, Hiba.
Yes, same place and same person. So we go all the way from the interface of the mucosa, and then we measure it. So using the intestinal ultrasound, so the probe will give you a magnified image. So once you measure it, it will be like clear. You go from the interface mucosa all the way to the serosa to measure. And 1 millimeter, yes, that's true. It will make a big difference because the definition of response is by a reduction of the bowel wall thickening by 25%. And sometimes we will have like a normalization. So when you come and I train you on how to do intestinal ultrasound, I show you how can you measure it precisely. It's not that difficult. Because we have layering and we have stratification, and we can consider it as a landmark from like where to start and where to stop. So yes, that's true. 1 millimeter will make a big difference.
Talal, very nice. UPA is the future for acute severe ulcerative colitis. We go straight away after steroids. John Marshall, you can comment.
Yeah, thank you, Hamad. There's certainly promising data in this class. So to me, they're quite effective, and they actually work very rapidly, which is one of their hallmark of the way JAK inhibitors work. I think, however, to this day, these patients are quite sick, and it's not the time to really experiment with these patients. And we know that the best data is for infliximab. And for this patient, for infliximab naive patients, you should be starting infliximab for these patients. However, JAK does, I think, has a promising role. I don't know about OPA, definitely TOFA, but OPA is I think, possibly were superseded later on. But in patients, for example, that are infliximab refractory, I think JAK is a reasonable alternative, and you know, I think we've tried it in our practice, and it actually does work very well. So yeah, I think it's sort of the new kids on the block, and I think eventually it might replace, you know, anti-TNF down the line, because our patients most probably will be TNF experienced anyway when they come to you in your center.
Yes,
Question, Professor?
two short questions.
Question?
Professor Sebastian, is there any place to use JAK inhibitors in a patient with history of thromboembolic manifestation?
With
Thromboembolism.
JAK inhibitors?
Okay, that's a really good question. So just on follow-up of that question, we just started the ACISO trial, which is upfront JAK kinase inhibitor along with corticosteroids versus corticosteroids and placebo. And that's exactly was the problem, because do we actually, you know, we certainly couldn't include patients with prior history of VTE in the trial setting. But what happens even while they are discharged after an acute severe UC on a JAK kinase inhibitor? Do we need to give anticoagulation? So straight answer, I'm very anxious about giving JAKs in previous history. If I do give it, I give it along with a DOAC, a direct acting anticoagulant. I got 2 or 3 patients who preferred with appropriate consent.
Thank you.
Thank you very much for this discussion and answering the discussions. Just maybe we'll close the panel discussion. One question?
One quick question.
Okay, Dr. Malak.
Dr. Hiba, I know there are many scoring for intestinal ultrasound. Some of them validated, some not. Do you use routinely in your clinical setting IBUS-SAS, or you just depend on bowel wall thickness?
Come again, because I couldn't hear you.
I mean, there are many scorings for intestinal ultrasound. Some of them validated, some of them are not. Do you use routinely IBUS-SAS, or you just depend on bowel wall thickness?
Yes, I do use the IBUS-SAS because it's the most validated score right now. So IBUS now in the process to publish like more precise score to be distributed internationally and to be the one that we can rely on in measuring, monitoring and diagnosing our IBD patients. But yes, in my clinical practice, I do use the IBUS-SAS score. Okay. And now we have also a scoring for the ulcerative colitis patients, the UC-SAS scores also. And it's very beneficial because once you monitor the patient, so you're going to rely on your measurements and the calculations that you get.
JAK inhibitors, Dr. Prof. Marshall. I'm sorry.
I was also, we're actually also doing a trial in Canada. We're starting a multi-center trial looking at UPA first, followed by infliximab if non-response versus just infliximab alone. Because that's one setting where sequential therapy could be safe because of the short half-life of JAK inhibitors. So that's the potential advantage of upfront JAK inhibition followed by infliximab.
Can I just ask John, just a question about your TRIUMPH study that you're doing in Canada. Just a question, why you elected to use the 10 milligram BID dose when there is obviously the data for the 10 TID and most of the other trials. What's your decision-making process for that?
It's purely a fear of lawyers, I think, because really that's just the approved dose, and it would have been much more difficult because this is a multi-center observational trial, so we can't, very difficult to have multiple centers using off-label dosing routinely. That's really the practical reason, yeah.